Well, it's a distinct honor to participate with all these experts, and so thanks for including me. The topic is iris tumors, when to worry. I'm Arun Singh from Kola Institute here. So, iris tumors present a unique challenge. They are actually quite common, maybe perhaps certainly the benign ones, and they are generally very small compared to other tumors that we see, and they represent large variety. And many patients are asymptomatic. They go for normal exams or contact lens evaluations, and they'll have normal vision. And so you end up with a patient who has no symptoms, and you see a tumor and you want to treat them. And so there is this acceptance hesitancy on the patient's part, and has to be understood. So the steps in management really are the initial diagnosis. You do a good slit lamp exam, and you can pretty much figure out what you think is going on. So that's your first thing. And then you may have one or two differential diagnoses, but you can only do a limited number of tests. You can only do, for example, three things: anterior segment, OCT. You can do a fluorescein angiogram of the anterior segment. You can do UBM. These are only three imaging tests that one can do to figure out what the tumor might be. And you really have four management options. You can either observe them if you think they're benign. You can biopsy them if you think they're more significant in some way, or you can radiate them based upon the biopsy results. So your options are kind of limited. And in this talk, I also want to highlight a new way of managing small tumors, which is kind of an excisional biopsy technique. So let's look at some of the clinical findings that might be relevant. So here's a patient with a pigmented iris tumor, and you can easily see seeding on exam and also on gonio. So this, I think, is an important finding. We all agree on that. Secondly, here is a patient again with a peripheral iris tumor, and you say, well, it's nothing, till you do gonio, and you can easily see angle and ciliary body involvement. You can see that on contrast illumination. And I want to highlight here that the OCT is not good for angle or ciliary body assessment, let's say ciliary body assessment. So for that, you really need a UBM. And in this particular patient, there was a ciliary body extension. One can see that by UBM. So what can you do? Well, you have again many options. You say, well, this is a nevus with iridociliary component. But most of us believe that if there's a ciliary body component, you really want to treat them, although there are instances of ciliary body nevi that have been excised and published. But here we went with FNAB, confirmed it to be melanoma, and put a plaque that has the least morbidity for the patient. Here's another patient with, again, angle involvement. One can see central displacement of iris. It tells you it's a ciliary body tumor with iris extension. And here this was excised, and histopathology showed it to be a nevus. So we talk about iris nevi and we talk about choroidal nevi. Well, here's a biopsy-proven case of ciliary body nevus. So ciliary body nevi also exist. It's just that we are not able to see them or diagnose them readily. So here's a young man who's 17 years old with an iris tumor. It's a stromal tumor. You can see anterior and posterior expansion of the iris stroma. And you say, oh yeah, this is a nevus. Well, I had seen him 5 years before, and I had a photograph from my assessments, and you say clearly a growth is present here. So a growing tumor, an iris pigmented growing tumor, to me is a melanoma. People may disagree with that, and we excised it. I did, and this was melanoma histopathologically. Here's the child after treatment. You can see people have been reconstructed, and it looks pretty good. So here's a patient with a vascular tumor. This, of course, is not melanoma. Most of us will agree on that. Could be inflammatory granuloma or metastasis. This was biopsied and showed it to be metastasis from renal site, renal cancer, and was treated with plaque and Avastin. So again, the vascularity of the tumor was concerning. Here's a patient with appears to be kind of darkish, cystic-looking lesion sitting on the iris. On fluorescein angiogram has no vascularity whatsoever. It's totally dark, so obviously it's not vascular. And on the UBM, one can say it's kind of sitting on top of the iris stroma. One can imagine normal stroma in the background here. So we say it's above the stroma, but we really couldn't tell. Of course, it's not melanoma, I would say, but we really didn't know what it was. So there's some issue with diagnosis. What is it that we're dealing with? We excised it, and because we thought the stroma was normal, we just kind of shaved it off on the surface of the stroma, and one can see after surgery, we have maintained the sphincter, and the pupil looks normal. And this happened to be an iris varix. It's a rare kind of a vascular benign tumor. Here the child, well, he's 18 years old, went for a contact lens exam, and one can see a amelanotic peripheral iridociliary tumor, which is highly vascular. It was not there the year before he went for contact lens exam. So again, recent onset made us think that this is could be a melanoma. It's highly vascular. We excised it by iridocyclectomy because it did go into ciliary body. That was a melanoma. Here's another patient with a very vascular, similar-looking tumor arising from mid-stroma of the iris on the fluorescein. You can see high amount of vascularity. A tumor like this, I'm hesitant to biopsy because they'll get hyphema. And this patient actually has no symptoms. Like I said, they're 20/20 vision, normal pressure, and they're walking around and you see a tumor. We excised it completely. It came out to be leiomyoma. Leiomyoma is a smooth muscle tumor arising from the smooth muscle, it seems, of the iris vessel. So there you go. You can't really tell easily, I don't think clinically, it's this or that. Here's another patient with a iridociliary tumor-like appearance. On UBM, one can see it's kind of invading the sclera. It's beyond its normal space, so to speak. We excised it and come back as sarcoidosis. So this is an inflammatory granuloma that mimicked a tumor. So not everything is a tumor necessarily, but you can see it. Some of them are large. So obviously this isn't a nevus, right? Most of us will agree that this is not a nevus. So I mentioned in my different cases certain features that I think are alarming to some extent where we would want to intervene. We did FNAB, put a plaque after that, and he did very well. I want to highlight another case. It's again a recently detected small tumor of the iris. It's kind of vascular. You can see that on the fluorescein angiogram. And we excised it. It's stromal. So we say, well, it's a nevus melanoma. We really can't tell apart. But because it had not been seen before, we had this clear documentation of his prior records, we wanted to excise it. So a traditional approach would be a wide limbal-based incision. You cut 1/3, 1/4 of the limbus and kind of cut it that way. But we used a different so-called laparoscopic or small incision approach. Multiple incisions here. You're cutting the iris. And I want to just show a quick video. So after you've done that and you've released the tumor into the anterior chamber, we are using this DSEC cannula, which has been loaded with viscoelastic, and you're able to aspirate the tumor right into this cannula. The advantage being that once you remove the cannula, you haven't really seeded the wound. The tumor came out totally protected. I think that's a good thing we like to see. We do not want to spread the tumor. And more importantly, now you just express this cannula or the tumor onto the filter paper. And so you have a tumor which has not been touched or manipulated and the margins have been maintained, and you'll get a good assessment on pathology whether you got clear margins or not. So he looks post-op 1 week, very good. He has no astigmatism and he did very well. So here's the sample. You can see very nicely that the tumor has not been crushed or rolled over. It's flattened, and you can see the margins, and margins were negative. So we can do it even for bigger tumors, for example, like this. Here's a young nurse from Pittsburgh area. Blue eye, Martine? Blue eye with brown tumor. And here it is, she was excised and she did very well. You can see the pupil is equal size in ambient light. Again, the suture goes near the collarette, and that will give you a good size pupil. So we published this study, and that's fine. So coming back to the biggest thing, at least in our practices, is it nevus or melanoma? And that's not a straight answer. It's kind of a little tortuous. And I don't think we have clear criteria to differentiate, but there are certain things that increase the probability of the tumor being a melanoma and less likely to be nevus. And one would say is a recent onset, like a case I showed here. Presence of growth, I think we agree to a large extent that it will go along with the diagnosis of melanoma. Tumor that's more than 3 millimeter in any basal, any diameter, I think thickness or base, either way, is more likely to be melanoma. Presence of vascularity, presence of hyphema, ciliary body extension, and angle seeding. All these things, I think, are the features that would make me think the tumor is melanoma versus nevus, or certainly malignant and not benign. And of course, in cases of diagnostic uncertainty, I would treat it with respect and try to get the diagnosis. I think with that, I've finished. Thank you so much for allowing me to share my experiences. Thank you.
All right. So may I request our Chairperson to please invite the next.